Hey guys, I am doing a podcast on fundamentals of chest x-ray. I think this is really important. A lot of people don't have the basics down or don't follow the basics, and there's really a simple way of reading a chest x-ray. We're not going to get into all the esoteric stuff that radiologists do because they're there for a reason, but you should be able to pick up the basic things. Line placement, pneumothorax, CHF, pneumonias, at least a simple pneumonias. Some can be more complicated. But we're going to go over a method of reading that should allow you to do this. So, hope you enjoy it. And for my anesthesia colleagues, I'm sure you can all identify with this. Anything that happens is blamed on anesthesia. The weather, crashing your bike, any car wrecks on the way to the hospital, it's all anesthesia's fault. So, the basic principles of reading a chest x-ray, you need to have a systematic approach. And the one I use is just ABCDE, where A, you're looking at the airways, B, you're looking at the bones, C, looking at the cardiac silhouette, D, checking your diaphragms, E is everything else. And we'll go over this probably ad nauseum during the lecture. You need to look at the clinical picture too. Just getting a chest x-ray alone without any clinical picture makes things difficult. It's so much easier if you have that clinical picture. So obviously if you're reading your own x-ray, you'll have that clinical picture, but if you send an x-ray off to a radiologist to be read, make sure you include a decent clinical picture that helps them out. If they have a previous chest x-ray, that's huge. You should be comparing it. It makes it really easy to pick out changes and just makes your life easier in general. So some of the goals of this podcast, especially for ER people and anesthesia people, line placement, obviously verifying any central lines that you put in, making sure that you don't have a pneumothorax either from the central lines or if you get a trauma in or whatever, and picking up congestive heart failures, pneumonias, and things like that. So before we get into actually interpreting the x-ray, let's talk about the view a little bit. So you have a PA view and an AP view. On the PA view, where the patient is standing up, the x-rays are going to penetrate through the back to the front where the film is. And I'm sure most of you have seen a patient get a chest x-ray where they stand with their chest up against the plate, and then the x-ray comes in through their back. AP is usually if they're on the bed and can't stand up for a PA film. And in that case, the x-rays are going to penetrate through the front to the back of the patient where they're usually laying on top of the film cassette. In a lateral, the patient is usually standing up with their left side against the cassette, and the x-ray penetrates first through the right side, hits the left side and into the cassette. A little bit about penetration makes it difficult to read. If it's under-penetrated, you might miss stuff. If it's over-penetrated, you might miss stuff. So make sure the penetration is adequate. Most radiology techs do a good job of this, but occasionally get one that's not ideal, and you may need to repeat it. We'll talk a little bit about rotation, where the patient isn't straight on to the film or to the x-ray, and there's ways to tell if they're rotated, and it can cause issues with making the heart look bigger, the mediastinum look bigger, etc. So let's talk about lobes. Real quick, I want to mention, and you'll probably hear me in this lecture saying either zones or lobes. Lobes are the actual lobes of the lung. And of course, the right side we have 3, the left side we have 2. The zones are different. You have upper, middle, lower zones, but that may not correlate with the actual lobes of the lung. And this picture you're looking at here is of a right upper lobe. And you can see on the PA film on the left, the lateral film on the right. That's where the right upper lobe lies. And here is the right middle lobe. Again, the PA on the left and the lateral on the right. And you can see that the right middle lobe overlies the heart, the right side of the heart border there. So if you happen to get a pneumonia, or you get an X-ray that has this side of the heart obscured and you can't see it, that would indicate that there's an infiltrate there, which could be a pneumonia and so forth. And you look on the lateral where the middle lobe lies, and again it lies over that heart right there. So if you are getting an obscuration, is that a word, of that heart, then it indicates that there's an infiltrate right there. And you can see the spine here, just real quick, on this lateral. And there's something called more to black sign, where you see how the upper spine, the vertebrae are white, and as they move down, it turns blacker. And that's a normal thing that you want to see. If it doesn't, or you see the spine, the vertebrae whiter down below here, then that's a sign of an infiltrate as well. And here is the right lower lobe. And these don't lie adjacent to each other, they're overlapping. So although it looks like it fills up the whole side of the chest, you have other parts of the lung overlapping this lobe. You can see on the PA on the left and the the lateral on the right. And you can see when you get a right lower lobe pneumonia, how that would affect that spine, the vertebrae there, and how it may cause, if you have a pneumonia or an infiltrate down in this part of the right middle lobe, how it would affect being able to see those vertebrae. Besides the more to black sign, a silhouette sign, it would also be appropriate. But the silhouette sign can be anywhere in the chest, where more to black is generally specific for the vertebrae. And the left upper lobe on the PA and the lateral on the right, you can see how it takes up a significant portion of the chest and covers the upper part of the left side of the heart. So if you get a silhouette sign, meaning that part of the heart is maybe obscured and you can't see it, or even all of the heart is obscured, that tells you there's probably an infiltrate going on there. And the same thing over here on the lateral. If the heart's obscured, or the upper portion of the vertebrae is obscured, then that tends to direct you to thinking about an infiltrate and what's causing the infiltrate. Left lower lobe, there's only 2 lobes in the left lung, of course. And you can see how the more to black sign on the lateral over here. If the spine does not get blacker the lower it goes, then that's an indication of an infiltrate. So again, down here, these might be white or whiter than up above, and that's something to pick up. Again, if you have an overlapping, or if you have an infiltrate and it obscures, say, part of the heart, that's a way of telling that there's an infiltrate going on there. And this just takes practice reading chest x-rays, looking at every one, and before long you can pick them out. And again, having a systemic method, which we'll go over here in just a minute. And this is very true, as my anesthesia colleagues will attest. Either 1950s, 2000, they're reading newspapers, and now they switched to smartphones and iPads in the OR. All right, so here's a normal chest x-ray. And I'll go over the ABCDE method here real quick. Get that off, the little something on the screen there. So start with A, airways. And here you can see the trachea coming down. I'm going to draw this out. And you can see where it bifurcates. Looks like it bifurcates right here. This is the carina. Excuse my writing. You can see you can trace the airway down here and over here. So if you're going to check for tube placement after you intubate somebody, whoops, you would look for the carina and then check for the tube about 5 centimeters above the carina. And I generally look anywhere right around the clavicles is great. So that's A, airways look good. B, for bones, you can check out all the bony structures. And you can see the clavicles look good. These are the posterior ribs here, because these are the anterior ribs. You can see I can trace this posterior rib to the lateral rib to the anterior rib where it comes around there. So this is anterior rib, anterior rib, anterior rib. These are posterior ribs. So anyway, you look at all the ribs, no fractures. Clavicles, no fractures. Look at the vertebrae, they look fine. Any parts of the shoulders that are in view, and they look fine. So that's B of the ABCDE method. C, cardiac silhouette. Come down here, check the silhouette. You can see the silhouette nice and clear. Nothing's obscuring it. Looks good. Heart's normal size. And on to D, the diaphragms. Here is the right diaphragm. Here's the left diaphragm. Left should be a little bit lower than the right, which it is, and that's normal. Here's your gastric bubble. So that looks good. Now there is something called a continuous diaphragm sign, where if you see this diaphragm going all the way across, that would be a sign of an infiltrate. If you see air in between the diaphragm, it might look something like that with a black space, and you see a nice diaphragm line, and that would be an indication of a pneumoperitoneum. E is everything else. You want to look at the lung fields. You can see good vascular lung markings all the way out to the edge, indicating there's no pneumothorax. You can see the lung markings all the way out. See these nice little vascular markings on both sides you want to check, and they go all the way out. So that's E. You can see this is a normal chest x-ray. So we spoke briefly about rotation of a film, and here is how you can judge that. You can see the clavicles here where they come up against the spine, and you can see the difference in width, and this tells you that the patient is twisted a little bit. So it may make the heart look bigger, the mediastinum look bigger or smaller, change it in other words, may make the heart appear more on one side or the other. So you just need to be aware of the rotation and if it is rotated. So to talk a little bit about the differences between AP versus PA view, here is the same patient. On the left you have the AP view, on the right you have the PA view. Again, the PA view is standing up with the film going from back to front. The AP view is either laying down flat or upright in bed, but the x-ray comes from the front to the back on this one. So you can see the difference. The AP view, the heart looks huge. But on the PA view on the same patient, the heart's normal size. And you just need to be aware of that when looking at AP views, which you'll look at a lot in the OR and ER. You can see the gastric bubble that shows up on the PA view because they're standing up and the gas is risen, and you can pick that out pretty easily. It's missing here on the AP view. You can see on the clavicles on the AP view how the clavicles are up higher than the lung fields. That's an indication that it's an AP film. You look over in the PA film and the clavicles are basically on the same level as the lung fields. You can also look at the shoulder blades here, and the scapula will be more out of the picture with a PA view, although here just a little bit, and then more in the picture on the AP view. Again, the mediastinum looks large here. You might freak out and go, oh my God, but it's really due to the type of film and how the picture's taken, AP versus PA. And here's what we discussed, ABCDE, airway, bones and soft tissue, cardiac and mediastinum, diaphragm, and then everything else for E. Effusions, lung fields, gastric bubble, etc. And it's really important that you use this systematic approach on every x-ray. Otherwise, you're going to miss things, I promise you. We miss enough not being radiologists to deliberately bypass these, and we'll tend to miss more. And here is an x-ray just showing the heart and the trachea. You can see on the right-hand side here, the heart that's already drawn out and the lung fields in green, the trachea in blue, just to kind of give you an idea. And I know we went over this a little bit already, but hope this is a little bit better picture. Okay, so A for airway here, and we're looking at the trachea. So here you look down, draw out the trachea, and you can see that it's kind of deviated off to the patient's right-hand side. And you think, well, what causes deviations? Well, things that push away are things like pneumothorax, pleural effusions, large mass. But some pathology will actually pull the trachea towards it. If you have an atelectasis, lobectomy, pleural fibrosis, things like that tend to pull that trachea towards the pathology. In this patient here, you can see they have a tension pneumothorax. If you look, well, let's go through the systematic approach here. So we did A. We see that the trachea is deviated somewhat. It looks like that's probably the carina right there. B, look at the bones. They're all fine. C, cardiac silhouette. And you can see the silhouette here is pulled or pushed towards the patient's right-hand side. D for diaphragms. The diaphragms are here. A little bit of a poor x-ray because it cut off the bottom margins there. And then E for everything else. We look on the left-hand side and you see good lung markings all the way out. But you look over here on the patient's left side and you see really no lung markings. See, there's no vascular markings here anywhere in here. And this is a really easy one to pick out. Some pneumothoraxes aren't. And this one's, again, it's a tension pneumo because it is pushing the trachea and the heart over to the patient's right-hand side. And you can see the lung right here. So that lung is pretty much totally collapsed there. This patient needs a chest tube like 5 minutes ago. I would imagine his vital signs are starting to show this because that's a lot of pressure that they're putting on the heart and great vessels. And I know they teach you to do a needle thoracostomy first, but I tend to just do a finger thoracostomy. It's quick, 100% effective pretty much, and you know that you've relieved it, where a needle thoracostomy, if you do the anterior way, which they don't recommend anymore, it's only about 65% effective. And a lot of people tend to go more medial, and you can hit the great vessels and hit things you don't want to. If you do the mid-axillary line where you do the chest tube, it's much more effective. So that's where I'd recommend. If you don't do chest tubes, put your needle there. If you do chest tubes, do enough to where you can do it under 30 seconds. You should be able to do a finger thoracostomy in under 30 seconds. It's quick, it's easy, and again, it's pretty much 100% effective. So on to bones. We want to look for fractures, any deformities, kyphosis, scoliosis on the spine. And then do you have lytic bone or osteopenic bone, which could indicate a cancer or other various pathologies. For what we do, that's probably not as important. The radiologist will pick this up, but you might pick up a cancer. But again, if I saw one, I would still wait for the radiologist to come back before I ever open my mouth to say anything about it. But it's still part of reading it, and when you look at the bones, you should be looking at that. Fractures, you can should be looking at all the bones and picking out the fractures. You can see here, if you do the A, Here is trachea coming down. Looks like the carina is difficult to see here, and I'll show you a method of picking out the level of the carina by counting the vertebrae just a little later on. And then B for bones, look at the posterior ribs, turn on the anterior ribs. And these here look good. Clavicle on this side looks good. Clavicle here looks good. This is the first rib up here. Looks fine. Second rib looks good. Some people say, oh, that looks like a fracture, but that's actually the anterior portion of this rib overlapping, so it tends to make that look like a fracture, but it's not. But you look here, you come here, let's see, 1, 2, the third rib here, and you can see this disruption right here. That's a fracture. And the fourth rib, you can see this disruption right here. That's a fracture. Fifth rib, sixth rib. Let me count those again to make sure. 1, 2, 3, 4, 5, 6. Yep. So it looks like he has fractures in 3, 4, 5, and 6 there. So that patient's probably not overly happy right now. Be a great candidate for either a ESP block or a serratus plane block. Take that pain away for hours and hours for my ER anesthesia colleagues. My ER colleagues, these blocks are easy to do and fantastic for the patient. Cuts down on morbidity, mortality, makes them way more comfortable, and especially if you ship a lot of patients, doing blocks in the ER for fractures and dislocations is just the bomb. So I got sidetracked. Let's go back here for some more fractures. And on the left-hand side here, you can see a fractured clavicle. This nice yellow arrow pointing it out to us. And you can see the disruption here. Right there's the fracture. You can look on the patient's left side and it's normal clavicle. On this one here, you can see a vertebrae here that looks like it's fractured. You can see the disruption in the body there. So you need to look at these bones. Whoops. Sorry about that. So you need to look at these bones when you do read films just to make sure there aren't any fractures. Especially in the ER. When you do an OR line placement, etc., I know you mainly look for, if you've intubated them, for the tubes, for the lines, pneumothorax, etc., but in the ER especially, you'll want to pick this stuff out. I briefly mentioned this earlier. This is a pneumoperitoneum, and you can see the diaphragm here, and air under the diaphragm. This is air, and here is the diaphragm, and this is all air. This is liver, and this, of course, is stomach over here. These are gastric bubbles, but this is all air from the pneumoperitoneum. So this guy needs to find a general surgeon to fix him. And again, A for airway. Come down, here is the trachea where it bifurcates. There's a carina. Bones, go out and look at all the bones. Ribs look good. Clavicles look fine. Vertebrae look good. And then on to the cardiac silhouette, mediastinum. Cardiac silhouette looks good. Mediastinum looks pretty normal. Aortic arch. D for diaphragms is where we picked up the pneumoperitoneum. E for everything else. This film looks like it's a little over-penetrated, and the vascular markings are not easily seen, but you can see them. Don't make the mistake of looking at an over-penetrated film where you see a lot of black and thinking it's a pneumothorax. You can pick out lung markings still that go all the way out. So on to C for cardiac. 2/3 of the heart should lie on the left side of the chest. If it's anything greater than, the heart should take up less than half of the thoracic cavity. Anything greater than or larger than that half could mean that there's a cardiomegaly going on. Left atrium, left ventricle, of course, on your left side of your heart border, patient's left. Right heart border, you'll see, is the right atrium. And here's a little picture kind of showing you aortic arch. This is the aortopulmonary window. It's a little space right here that you can see. Pulmonary artery, and then down here, of course, is left atrium, left ventricle. On the patient's right, you only see the right atrium right here. This is where the right pulmonary artery is, and of course, ascending aorta is over here. Usually you can't see it. At least I can't. Radiologists can, but they're magicians. It's witchcraft, I tell you. D for diaphragm. We went over this a little earlier. You got the right diaphragm here, left diaphragm a little bit lower, which is normal. Of course, there's your gastric bubble. If you're looking at the lateral view, again, the right is going to be higher, and you can see the right here, and it then goes lower as it reaches back around the spine. Left starts off lower and then ends up a little higher around the back by the spine. Talk a little bit about lung fissures. Sometimes you can see these, especially when the patient has an excess of fluid, congestive heart failure, pulmonary edema. This is the horizontal fissure. This is the one I see most often if the patient is fluid overloaded. The oblique fissures here and here, I don't see those too often. Sometimes the radiologist can pick them out, and I'm like, what? On the lateral view, horizontal fissure, oblique fissure. So keep your eye out for those. If you do, or if you are able to pick them out, then start thinking along the lines of excess fluid in the lungs. Or sometimes you can pick them out if they have a really good consolidation infiltrate that's really defined in one lobe, like the right upper lobe, right middle lobe, which is this area here. This is right lower lobe. Of course, this is right upper lobe. And left upper lobe. Your lingula is in here, but we'll talk about that a little bit later. And then your left lower lobe. All right, so this one here is of a right middle lobe consolidation. Most likely it's a pneumonia. And again, if you could do the ABCDE method, you come down, look at the airways. Looks like the carina is right about there. And look at the bones, they're all fine. See cardiac silhouette. So you can't really see a cardiac silhouette here on the right side. It's being obscured by that infiltrate there. You should see that heart there. So that tells you that there's a consolidation there. Look at the left side, it's fine. Look at the diaphragms, they're fine. Not that they're cut off a little bit there, but that's all right. And then E for everything else, you have good lung markings all the way out on both sides. So this patient looks like has a right middle lobe pneumonia, and it'd be interesting to see the lateral view as well, but they only give you what looks like the AP view. You can see how the clavicles, even though they're cut off, look to be quite a bit above the lung fields, as well as you don't see a gastric bubble. Of course, part of that's cut off anyway. So yeah, it looks like right middle lobe pneumonia on this patient. And this one here is, again, pretty easy to see. To go back to our method, you can see the trachea coming down. You can't really, it's pretty difficult picking out the carina. So it makes it a little difficult seeing the carina in this picture. And I know I've talked about the thoracic vertebral bodies, and even those are kind of difficult to see here as well. So you can also go by the ribs, and you can see this is the first rib here, coming up there, kind of cut off a little bit. Same thing on this side. This is the second rib. So if you count the ribs down, they should correspond to the vertebral bodies. So 1, 2, 3, 4, 5, 6. And the carina should be between the 5th and 7th vertebral body. 7. So the carina should be between here. And again, if you have your ET tube once again above, or I'm sorry, about the level of the clavicles, you should be okay. But this is another way of determining approximately where the carina is. But anyway, so that's airway. B for bones, we did the bones. C for cardiac silhouette, and see the cardiac silhouette here. And the cardiac silhouette looks difficult to see on the patient's left-hand side. You can kind of sort of pick it out there, though. But when you go on to, oh, let's do D for diaphragms, there you go. E for everything else, the left side, good vascular lung markings all the way out, so that's fine. And this is breast tissue, that little line there. You can see the breast on the other side as well. Oops, sorry, my computer was going crazy there. And so E for everything else, back to the patient's left side. You can see there's really no vascular lung markings anywhere in here. And so you have a pneumothorax, and again, you see a little bit of a shift of the trachea. So there's some tension on there. So I would be not wasting much time in getting a chest tube in this patient. Again, you can kind of see the lung there. So you can see if you do the method, I mean, this here obviously just jumps out at you. But again, many pneumothoraxes are much more difficult to pick out. And when you see one thing, human nature, you tend to forget everything else, and you might miss the second or third thing that might be going on. We talked a little bit about cardiomegaly. And again here, the cardiac ratio, you can see the heart here is less than half the size of the chest here. So that would be an appropriate size, where on this one here, you see this is a huge heart. See the heart here, and it's way over the ratio of 50%. So that would be considered a cardiomegaly there. Time for another joke slide. Again, directed toward my anesthesia colleagues. I hope nobody takes offense, but as everyone knows, anesthesia is the only profession where everyone wants to squeeze your bag and use your pole. And the people in the OR, you know that. They're always trying to take your pole that you need for different things. And I think they're secretly jealous that you get to squeeze the Ambu bag. And I talked about this, counting vertebrae. This is a much better film to determine where the carina is. And you can see here, the first rib is back here, and it comes up like this. This is the second rib. Second rib. You see second rib corresponds to T2 here. T3, T4, T5, T6, T7. So the majority are between T6, T7. You have a few outliers. I've seen references say T5 to T7, but I usually place it, somewhere between T6, T7. That's fine. And again, if your ET tube is about clavicle level, slightly below, then you should be fine. This is invaluable because a lot of the chest x-rays, you may not be able to pick out the carina, especially if you're new to reading chest x-rays. And this will help you find it, or at least make sure your ET tube is above it. And here we're just looking at carina, and this looks like a line placement here. All right, so I keep hitting the wrong button. I use a program called Snagit to record this, and one button to the left of where I should be hitting stops it and saves it and ends it. So I've done that twice now. I'm going to have to try to piece this together at the end, but it's really irritating. So anyway, here is a film. Looks like they're doing a line placement, and we'll start off by tracing the trachea, A for airway, down where it bifurcates right and left bronchus. There's your carina. B for bones. I'm not going to mark it up because I want to be able to see that line clearly. Look fine. Of course, we only see the right-hand side anyway, so we're going to have to skip a lot of this. C for cardiac silhouette, and D, we can't see diaphragms, E for everything else. Okay, so E for everything else, we look at the left side only since that's what is given here, and you see good markings, good vascular markings all the way out. Of course, this is scapula here. Don't confuse that with a pneumo. Here's your first rib, and this is second rib, third rib, fourth rib, fifth, sixth. And of course, we see the carina really well here. You want a CVL. If it's for short-term use, then just above this tip, just above or right at the carina is fine. If it's for longer-term use, you're going to want it down a little bit further and down around the cavoatrial junction area. But I always place mine up here. I don't, if you're a general surgeon putting in a portacath or something, you'll want it down a little lower, but I tend to place mine for more short-term use, obviously. And so mine are always placed up here. You can see that the tip is, the whole thing is below the clavicle, which you want. This distal end, it's important that it's vertical, so it's not horizontal where it might be pushing up against the vessel wall. We don't want that, obviously. And it looks like the tip, which is right here, is just above the carina. It looks like a centimeter or so above the carina. So this vertical tip is important. It's not so much when you do the patient's right side, but when you go in on the left side, a lot of times it comes across, and if you don't put it in deep enough, it'll end up kind of like this, where that tip is up against the vessel wall, and you can cause some major complications. So you need to put it in, and you actually might need to go a little further just to get it directed downward in the vertical position. But this is a good placement, good line placement here. And here is another film, again line placement. This one's coming in on the left-hand side of the patient. Let's start off, look at the trachea. Trachea is awesome here. See where it bifurcates right in the main bronchus. Here's the carina right there. And it looks fine, not shifted, etc. You look at the bones, bones are all okay. C, cardiac silhouette, that looks fine. D, your diaphragms, look fine. Then E for everything else. Look on the patient's right side. Looks like you get good vascular markings. Patient's left side, good vascular markings. So you know you don't have a pneumothorax over there. And then look here at the line. And you can see this line coming in here and across and down to here. So here's the tip right there. So you can see the tip is positioned vertically, which is good, just barely. You can see how if you didn't put it in far enough, though, and stop there or there even, then you most likely are up against the vessel wall, which can cause some pretty serious issues. But here the tip is vertically, and the tip is just below the carina, which is fine because you had to put it in a little bit further. If you ended up with it above the carina, then again you would be up against that vessel wall, which you don't want. So this was put in a little further, a little bit below the carina, again, which is fine, and to make sure that tip is positioned vertically. And another film here. This is an interesting one. Let's start off. So again, the clinical picture really helps. You just get a chest x-ray and it's like, well, pick this stuff out. It does make it more difficult. So if you do have the clinical picture, it's easier. We'll just say this patient was short of breath and came in to the emergency room. So we'll start off with A for airway. Here's a trachea. Here's right and left bronchus. This is the carina. So the airway looks pretty good. And bones, we'll just say the bones are all okay. I don't see any fractures, ribs, clavicles. Vertebrae are kind of hard to see. So C for cardiac silhouette, it looks pretty good. Looks like a little perihilar fluffiness there, but we'll skip that for now. D for diaphragms. There's your right diaphragm, here's your left diaphragm. So you're like, well, this is odd. This is really a deep diaphragm there. And this is a sign called a deep sulcus sign. And it's indicative of a pneumothorax. So this is an AP film. You find the deep sulcus sign on AP films when the patients are lying flat. You can see that the mediastinum looks a little wider, which is due to being the AP film. The clavicle is up above. You see how the clavicles are up above the lung fields. So this is also an indication of an AP film. So this deep sulcus sign tells you that there's probably a pneumothorax going on here on the right lung of the patient. And it's an important sign to remember. It's usually pretty easy to pick out because you can see how deep this costophrenic angle is as compared to the patient's left side. And the diaphragms are almost level as well. That's really an interesting chest x-ray there. So here's another interesting one. Let's start off doing A for airway. Here's your airway. You see it bifurcates. Looks like the carina is going to be right about here. B for bones. Bones all look pretty good. Clavicles look all right. I don't see much in the shoulders. Vertebrae you can see, and they are looking okay, or the ones you can see anyway. And C for cardiac silhouette. It's looking okay. D for diaphragm. Here is your left diaphragm. I'm sorry, your right diaphragm. Here's your left diaphragm, but it looks a little odd. You can see air underneath the diaphragm. This is air. That's your gastric bubble. So this patient has a pneumoperitoneum we found. So go on to E for everything else. Has good lung markings all the way out. So I don't see a pneumothorax. No pneumonias we found, etc. But this patient does have a pneumoperitoneum and needs to visit with a general surgeon. And here is a really interesting chest x-ray. So parts of it are cut off, excuse me. We'll do A for airway here. You can see the trachea coming down. Looks like it bifurcates about there. That looks like carina. And B for bones. So you can see the rib. That's a first rib up there. Here's second rib, third rib. They look all okay. Clavicles, part you can see. Looks all right. Don't see any fractures. Okay. But you do see a couple funny things. We'll pick that up here in a second. C for cardiac silhouette right here. D for diaphragms. What diaphragms you do see. Oops, can't draw. All right, E for everything else. So let's do patient's left side first because we know something's going on with the right side. And I see good lung markings all the way out. So left lung looks fine. But you look here on the right lung here, right off the bat you can see a chest tube. So here's a chest tube. And up here you can see a lack of vascular lung markings. Look how you don't see any lung markings up here. Yet down here you see the vascular lung markings pretty well. So you can see this patient still has a pneumothorax even though they have a chest tube in. You can see the pleura right here. Oops, looks like it comes down here actually. So this patient still has a pretty good size pneumothorax. I would check this chest tube and make sure the holes are, chest tube holes that you find are all the way inside. Make sure it's not plugged, but something's going on and this needs to be corrected here. So you've picked out, patient has a pneumothorax still in spite of already having a chest tube inserted. It probably needs to go in a little bit further. And another chest x-ray. Let's start with the A for airway. Looks like it bifurcates there, so that's your carina. And it looks in normal position, although you do see something coming down here, which looks probably like an NG tube. And if you trace it out, it goes down here for some odd reason. So why would an NG tube be in the trachea, the right main stem bronchus, and then down into the lung? Well, obviously it was misplaced, and they really put it down there. So right off the bat, we found a misplaced NG tube. So let's go on. B for bones. Check the ribs, clavicles, vertebrae, etc. All look fine. C for cardiac silhouette. The patient's right, a little difficult to see here. You can see the ribs clearly. So he may have a little consolidation going on over here as well, because you can't really pick out the cardiac silhouette. D for diaphragms. Here's diaphragm on the patient's right, patient's left. Can't really see that because it was cut off. A lot of gas in the air in the stomach. Probably needs an NG there. What do you think? And then E for everything else. Looks like there's good vascular lung markings all the way out. This is scapula. Don't mistake that for pneumothorax. And I had the advantage to be able to use my iPad to make this image larger because it's difficult to see, but there are lung markings out there, even though it's difficult to see here. If you have an iPad, you can make this bigger and see those markings as well. Just have to take my word for it. So pathology here looks like they have an NG tube down in the right lung and needs to be replaced. And here's an interesting chest x-ray with a lot going on. So let's start off using our simplified method here. A for airways. Come down here. You can see the trachea. Looks like the bifurcations right about there. It's carina. And it looks fairly good. Looks like it's fairly centered. B for bones. I don't see any fractures. Ribs all look okay. Clavicles, shoulders, what we can see. Vertebrae look pretty good. C for cardiac silhouette. You can see the right hand side here pretty well. Left hand side though is totally obscured. So what's obscuring it? Well, there's a lot of crap here. So that looks like a consolidation there. So that's one thing we found. So go on, D for diaphragms. You can see the right diaphragm here, gastric bubbles. Left diaphragm, partially visible. You can't see it here, and you can't really see it over here where it goes down. You can see that there's a kind of a line here, and that is a fluid in the right lung. It's, blood, fluid, whatever. I don't have the patient history, so I don't really know. So that's D for diaphragms, E for everything else. So you see a pacemaker. You see the leads coming down. Lead and lead. And that looks all right, although that's more radiology territory as far as I'm concerned. So the lung markings, let's do left side first. And you can see the lung markings go all the way out. This is breast tissue. Lung markings go all the way out, so that's good. And the patient's right side, though, you can see lung markings out here. We already talked about this fluid that we found, that effusion. Lung markings. But up here, you see the difference between the lung markings here and how this side doesn't have really any lung markings. and lung markings here versus over here. And you can see the pleura, if you look close, right here. That's pleura. So this patient has a pneumothorax as well. Looks like it comes here. So this patient has an effusion, possibly consolidation, and a pneumothorax here on the right-hand side. So I would say that he is going to be getting a chest tube. So pleural effusion as well as a pneumothorax. That was an interesting chest x-ray. So on to the next. So this one is interesting. I wish that it wasn't cut off, but we could see the whole thing, but still you get to see the parts you really need to. Just kind of a crappy chest x-ray. So let's start with A for airway. You can see the trachea coming down here. Although it looks like it's a little shifted. Can't really see carina. Just difficult to see. So that's airway, but we see something next to the airway here. Looks like an endotracheal tube coming down, but it doesn't appear to be in the trachea. So the FBI would call that a clue. Keep that in mind. B for bones. Okay, we looked at the bones. Not much going on. C for cardiac silhouette. Wow, looks like a big silhouette here. D for diaphragms. Here's your right diaphragm. Here's your left. Look at this air. Holy moly. This stomach is full of air. And I wonder why. When we think back to that clue, we have an endotracheal tube next to the trachea, so it's probably in the esophagus. So this patient's having a really bad day. He's obviously still has his lungs somewhat inflated. We see now why this left-hand side is so, the volume is so low. Right is a little bit better, but he has an endotracheal tube in the esophagus instead of the trachea. He also has an NG tube. You can just barely pick out here. It's kind of behind the endotracheal tube coming down. But you really need to blow your picture up to see it. And I don't see it crossing over down here anywhere. And I don't see it in the stomach, so I'm not sure if it's really correctly placed or not. But in any case, that patient needs to be re-intubated like really quickly. And next film, oh, this is really interesting. So, even though we see lots of stuff, let's do our run through here with ABCDE. So you can see the trachea here is really shifted. And you can see that there's an endotracheal tube here, ending there. Looks like this is the carina. That's your left main stem. And this is your right main stem coming down here. So right off the bat, we can see that this endotracheal tube is way low. You can see the clavicles are up here. I know I've said it before. I usually try to have my endotracheal tube at or just below the clavicles. You can see the carina and the tip of the ET tube, so that's way low. It should be 5 centimeters at least, 5 to 7 above the carina. So this is a right mainstem intubation, tells you right away. And going on, bones, okay, we look at the bones. C, cardiac silhouette, well, yeah, good luck with that. D for diaphragm, oops. Sorry, I'm doing this on a Surface Book 2. My palm keeps hitting the edge to change slides. Sorry about that. So anyway, I forgot where I was, but you can see that it's right mainstem bronchus, or I'm sorry, it's right mainstem intubation, and this tube needs to be pulled back. if you look at, we tried to do C for cardiac silhouette, can't see. D for diaphragms, can't see. Look at everything else. You can see this right lung is really hyperinflated. A lot of black, but you can see lung markings. So there's not a pneumothorax going on. Left side, though, is pretty much collapsed. You can't see much of anything. Pretty much whited out because all the ventilation is going to the right lung, of course. And all this extra ventilation and hyperventilation has pushed the trachea over and the heart because you can't see any silhouette on this side. And so, yeah, this patient needs to be that endotracheal tube pulled back really quickly. I'm surprised they couldn't pick this up clinically without having to pick it up on a chest X-ray. This is pretty bad, actually. I would say they need to hone their clinical skills a little bit. And this here also would be where ultrasound would shine, because you could pick this up in seconds as well with an ultrasound instead of having to get a chest X-ray, which takes time, and get it back and get it where you can look at it and so forth. If there's any doubt, you could pop an ultrasound on here and in seconds see that this left lung is not ventilating, the pleural is not sliding, and then you could run through your differential of, well, why not? Remember, with ultrasound, you can rule out a pneumothorax. You cannot rule in a pneumothorax unless you find a lung point. Of course, that's for a different lecture. But you can at least see that there's no ventilation or the lung's not moving on the left side with ultrasound, and then you could wonder why. But really, your stethoscope here should pick it up. The nurses should pick this up. All right, another chest X-ray. Let's see what's going on here. Looks like quite a bit. Let's start off with A for airway. You can see the trachea coming down. Looks like it bifurcates. Oops, like right about there. This appears to be the carina. Looks like there's an endotracheal tube right here. So that's okay. It looks like maybe 2 centimeters above. I would rather pull it back a little bit, but it's fine. It's above the carina. B for bones. Kind of difficult to see here, the ribs. A little underexposed, I would say. Okay, I don't see anything. Cardiac silhouette, again, difficult to see. So, looks like the gastric bubble, looks like this diaphragm, this is just a mess here. This is one that I would definitely want a radiologist to overread, but for our purposes, we know the endotracheal tube is not right mainstem, although it does need to be pulled back a little bit. Looks like this is the right diaphragm. This left diaphragm, though, I just can't really see it. And I'm wondering if it's not elevated and maybe this is a gastric bubble right there. So I think they've got something going on here in the left lung. And it looks like the volume and lung is diminished as well. Also has a central line. Here's the line coming down here. And this is a problem because you see the tip ends right there. It's up against that, up against the vessel wall, so that could perforate that and cause some major issues. So yeah, this is not a good chest X-ray. One, he needs to pull back. Oops, sorry about that. Needs to pull the ET tube back. And 2, this left-sided IJ needs to be advanced further. And then 3, you got to wonder about this left lung. Is it due to poor expansion? Like maybe that endotracheal tube might, even though it looks okay, might be down a little bit, because it's kind of borderline. Might be a little bit right mainstem. Or is there a consolidation or process going down here? With this gastric bubble, and I'm pretty sure that's a gastric bubble, up high, I tend to, first on my differential would be pull this ET tube back some and repeat that chest X-ray in a bit and see if that didn't correct it. That would be my first thought. But again, Sometimes this goes into radiologist helping you out, and this may be just one of those times. A really interesting chest x-ray, though. All right, so here is a chest x-ray. And let's start at the beginning. A for airway. Here's the trachea coming down. A little difficult to see, but I believe this is probably carina. If we count down, here is the first rib and second rib. So that would be T2, T3. A little hard to see down below. Oh, doggone it, keep hitting it. My big hands. So let's see, back to here. Here's first rib, so that's T1 here. T2, looks like T3. So 1, 2, 3. Here's fourth ribs. This would be T4, T5. Looks like that's the end of it. Looks like this is T6. So, yes, I think we're right. I think that's carina right there. All right, so that's airway. B for bones. Bones all look okay. C for cardiac silhouette. You can see it clearly. It looks good. D for diaphragm. Here's a diaphragm. This is breast tissue. This is scapula. A lot of people, when they first start reading chest x-rays, say, oh, there's pneumothorax, but it's just scapula. Scapula. You can see lung markings all the way out on both sides. We go to E. Here's breast tissue. Here is your left diaphragm, gastric bubble. So that's all normal. So you can see also, for everything else, this portocath here, and you can see the line coming here and then down. It looks like it ends right about there. So the tip is below the carina. Carina's up here, that's fine. This is long-term use, you want it down lower, and this is right about the cavo-atrial junction here, which is proper placement for a long-term line. So I would say that this is a good x-ray, and the tip is an appropriate position there. Now here's a nice one. So let's start from the beginning, although you can't see a whole heck of a lot, can you? So it's cut off, so that kind of hurts. I'm trying to find the trachea. I think I kind of sort of see it maybe here. Maybe this is a carina. In any case, it appears to be shifted over to the patient's left quite a bit, which is kind of concerning, right? B for bones, that's okay. C for cardiac silhouette. So you can see the left silhouette there, and you don't see any of the right silhouette at all over here. This may be the right silhouette. So the heart is really shifted as well. So the FBI would call that a second clue. Diaphragms, you have your right diaphragm, your left diaphragm here. And you can see this sulcus is really deep again as well, so that's a clue. But you go on to everything else. We'll go ahead and look on the left side here. Good lung markings. Low volume, though. Look at the patient's right side, and you see no vascular lung markings at all over here. Just none. And this here, so obviously has a pneumothorax. This here is the lung right here. So this is a tension pneumothorax because the trachea, heart, all your major vessels are pushed way over the patient's left side. I would imagine he's not doing very well. Just on a side note, you see this deep sulcus sign here as well. That's just interesting for us nerds. You don't really need it to diagnose this pneumothorax because it's really huge and it's a tension pneumothorax. So this patient obviously needs an emergent chest x-ray, I'm sorry, an emergent chest tube needle thoracostomy needs to be fixed like real quick. And all this pressure is what's making this left lung small as well, lowering the volume. There's just so much pressure, you just can't get it inflated very much. I would imagine this patient's probably hypotensive and so forth. It's really profound when a patient has a tension pneumo or develops a tension pneumothorax in front of you. It's just incredible how hypotensive they get and how it almost immediately corrects itself once you release that pressure. I had a ATV accident that had some neurotrauma that I had intubated in the ER, and the respiratory therapist said, hey, she's getting kind of hard to ventilate. Hit the blood pressure and suddenly 50/20, where before it was just fine. And it just happened, boom, just that fast. And I did a finger thoracostomy, and blood pressure popped up normal, blah, blah, blah. But just really interesting to see how quickly. And if you miss that, it doesn't bode well for the patient or for you. And another interesting chest x-ray here. Start off with A, kind of difficult to see the trachea and where it bifurcates. Not a whole lot of help here. All right, well, on to B for bones. C, cardiac silhouette. Although, real quick, you notice this patient's really twisted. This clavicle here is way over midline versus this clavicle, which looks like way out here. Hard to see. In any case, this patient is really twisted, so that's why you have your diaphragms kind of off. Nope, run out of battery. I may have to finish this a little bit later. Although there's a large gastric bubble in there as well. You see a lot of air. D for diaphragms, E for everything else. Looks like there's good lung markings. Good lung markings. There's a central line here. It's probably a PIC line. It comes from here, but it goes up into the patient's neck, so that's not good. And we all know PIC lines can do that. Also, subclavians can do that. So this line needs to be withdrawn and then readvanced and hopefully go the right direction this time. That's all I see on this chest x-ray. And I'm going to stop here, charge the battery, and finish later. All right, so here's another chest x-ray, and we'll start off with the airway. You can see the trachea coming down. It's a little hard to see the bifurcation here, so if we wanted to find out where the carina was, we could count. You can see the first rib is right there, and this is second rib, so that's T2, T3, T4, T5, T6. So your carina is going to be right in this area. So if you were seeing where your endotracheal tube is, then that would be the point, and you'd want to be about 5 centimeters above that. Now this patient has a central line here. You can see it's coming right here, and the tip ends right there. So it looks like it's probably a little bit below the carina, but still above the cavoatrial junction. So it's appropriately placed. You can see it is vertical, so it's not horizontal or up against the wall. And if you wanted it for long-term use, you could probably put it down just a little bit further down to the cavoatrial junction. But I would be happy with that placement. And cardiac silhouette looks fine. Diaphragms look fine. Gastric bubble. You look at the lungs, everything else, and has good vascular markings all the way out. So I would say that central venous or central line here, and it's appropriately placed. So here's a twofer. You have a two view of the same patient, and it looks like this is your PA and this is your lateral. So let's start off with airway. You can see the trachea coming down here, and here's a bifurcation. That's your carina. It looks fine. B for bones. Ribs look good. Clavicles look good. Vertebrae are a little hard to see. Mostly look good. Okay, C for cardiac silhouette. Here's your cardiac silhouette here. That looks fine. D for diaphragms. So here is your right, but it looks like it's a little obscured over here. And here's your left. Left looks okay. And everything else, lung markings all the way out. Lung markings all the way out. So, but you look here, and this diaphragm here is obscured, called the silhouette sign, so you know something, a consolidation is there. And you can see all this fluffiness in here as well. So they have a infiltrate / consolidation here. It's probably a pneumonia. So you want to tell where it is. So we can see, we know we can see the silhouette of the cardiac silhouette here. It's not being blocked. If this infiltrate was blocking that, then you would know that it would be in the right middle lobe. Since it's not, and it's below where the fissure is, it looks like you can kind of see the fissure here, possibly. It's right lower lobe. But you can really verify it if you look over here on the lateral film. And remember we talked about the more to black sign on the spine. You look at the vertebrae here. As you go down, it should get blacker. But instead, it gets lighter. Look how light these are compared to this. So it's backwards. So this tells you that there is a infiltrate over these, where the x-rays are going through to see. So this area here is, since you know it's on the right side, you know this would be the right lower lobe. If it's right middle lobe, it would be this area here kind of covering the heart. So this tells you, you know it's right side from looking over here at the PA, and then you know it's right lower lobe. Really verifies it by looking at your lateral here, by this, the loss of the more to black sign, or you can also call it a silhouette sign, of course. All right, so here is an interesting, really interesting chest x-ray. And let's start off, looks like this is the trachea here. It's kind of difficult to see, but it almost looks like it comes down here. I can't really see. This may be the bifurcation, but that seems to be up kind of high. So anyway, let's go into B for bones. Ribs look okay. C for cardiac silhouette. So here's cardiac silhouette, and it seems to be pushed into the right side. Oops. It seems to be pushed more to the right side here. Can't really see the left silhouette very much. This may be part of it. Diaphragms, and this diaphragm is missing. Can't see this at all. And let's do everything else. Let's start with the right side. Looks like it has good pulmonary vascular markings all the way out. But you look at the left side here, there's no markings at all in here. So you know this patient has a pneumothorax. Looks like the trachea and the heart are both shifted. So by imaging, this is a tension pneumo. Again, you need to take the clinical picture. And a friend of mine, Jason Tangway, who's an emergency room physician, brought this point up that I didn't realize before, is that you really need to have a clinical picture of a tension pneumothorax as well. So in any case, we're just looking at x-rays alone, but I would call this a tension pneumo. So you look at, and this is the pleura right along here. And here is fluid or blood. You see this nice level that there is here. It kind of goes across straight. And that tells you it's a fluid. And you look over here and you see a lot of subcutaneous air here. And it looks like, let me, So this patient has some pretty serious issues going on, and obviously needs a chest tube inserted to fix him. And for my anesthesia colleagues, I'm sure you guys have all seen the surgeons do this when you're turning over a room and it may take a few minutes longer and they're standing there staring at you trying to stay hidden. And this is pretty classic. So this is the end of the basic chest x-ray podcast. I hope y'all enjoyed it. I kind of tried to stick to mainly central lines, endotracheal tubes, pneumothorax, and a couple of pneumonias. Just the basics is really all you need. If you practice this and using the ABCDE method on every chest x-ray you see, you'll start picking up the pathology, and it just takes practice. So anyway, hope you enjoyed it, and we'll see you with the next podcast.